Good afternoon, everybody. Dr. Michael Jacobs here at the Fertility and IVF Center in Miami with our Monday midday Instagram chat. Today's topic is IUI versus IVF, what's best for me? And for those that are unfamiliar with those two abbreviations, IUI stands for intrauterine insemination and IVF stands for in vitro fertilization. And when we look at these two procedures, they're basically the most common things that we have to offer a couple trying to get pregnant. So it's important to understand the differences between the two and when one might be preferred to the other. Often one can be used as a trial, and if not successful, then move to the other. But in essence, IUI, or intrauterine insemination, used to be called artificial insemination. It's done by washing the male partner's sperm in the lab and then taking the most active, best portion of the sperm and using a very fine catheter and putting that sperm up into the uterus so the sperm don't have as far to go to reach the eggs. And the timing of it is very important because from a practical side, once sperm is either ejaculated or placed in the uterus, that sperm is on average good for about 24 hours. I mean, the Guinness Book of Records is probably 4 or 5 days, but in general, most patients' sperm will survive around 24 hours. And once the egg ovulates, it's only capable of being fertilized for around 12 to 24 hours. So there's a very tiny window in the month when you can get pregnant, and it's related to when that egg ovulates and when the sperm is available to fertilize that egg. And so in our center, we find we get much better results when we time intrauterine insemination with the use of a fertility drug that allows us to coordinate ovulation on the female side. So we usually use a combination of what's called ovulation induction with timed intrauterine insemination. And intrauterine insemination can be with your partner's sperm, or in a case where there's no sperm on the male half of the couple, or we're using donor sperm because of a social situation, whether it's a single female or a gay female, or the husband doesn't have any sperm. All three of those are very good reasons to use donor sperm and intrauterine insemination. The way it's done is for us to figure out exactly what window there is when ovulation is going to occur, and for us to time the insemination at the time of ovulation. We get a sample from your partner, it's processed in the lab, and with a very fine catheter, we can place the sperm up into the uterine cavity. We have you hang out for about 15-20 minutes at most afterwards, and then everything is just like normal, and hopefully we have a positive pregnancy test 9 days later. When you're doing intrauterine insemination with an ovulatory drug, we're trying to recreate what happens normally on ovulation. We're just kind of fine-tuning everything. So the goal is, particularly in someone who doesn't ovulate at all, to produce 1 egg or at most 2. And in patients who have unexplained infertility and ovulate on their own, but just aren't getting pregnant because the sperm isn't normal or the timing is not right, then we try and stimulate with a fertility drug to get at least 1 and no more than 3 eggs to be produced at the time that we inseminate. IVF, on the other hand, is a different approach. With in vitro fertilization, we're purposely trying to get multiple eggs. So we use injectable fertility drugs to produce hopefully 10 or 15 eggs or even 20 eggs in a cycle. And that's often very easy to do in somebody who's younger, who's 28 or 30 years old. But as you age and you have less ovarian reserve, even high doses of fertility drugs will tend to result in less number of eggs being developed. But we do IVF, we stimulate the ovary to produce eggs, we remove those eggs in the middle of the cycle by ultrasound guidance. It's done under sedation, so there's no pain involved at all. And then under the microscope, we can actually take the sperm and inject a single sperm into a single egg and force it to fertilize. Let that embryo develop for 5 to 6 days, and then transfer the embryo back into the uterus. Or if we like, we can biopsy that embryo and freeze it, And by biopsying it, you can test it for aneuploidy, meaning we check to see that it has the correct number of chromosomes present so that it has a better chance of sticking and not miscarrying and resulting in a healthy baby. So when do we do one, when do we do the other? When we're dealing with just an ovulatory issue and we're doing insemination just to optimize the timing of things, but the real problem is ovulation, then IUI is the first place to begin. And we do that with an ovulatory drug. Similarly, if we're using donor sperm for IUI, and it's the female that we're inseminating has good ovarian reserve, we usually will try IUI for 3 or 4 cycles, no more than 6, before moving to IVF. If we have a couple where the sperm is compromised, where we're not dealing with a normal sperm count, then, and that's the major reason that the couple's not getting pregnant, pregnancy rates doing nothing are very low. Pregnancy rates with IUI will be better than doing nothing, but the lower the sperm count, the lower the potential of success with IUI. And so IUI success rates vary depending on what the cause of what we're treating. If we're treating just an ovulatory issue, then we'll get pregnancy rates of 18% with normal sperm. If we're treating unexplained infertility with Clomid as an oral ovulatory drug, we're going to see pregnancy rates of only about 8% per cycle. Now that's a lot better than doing nothing after a year of trying to get pregnant, where you see less than 1% per cycle, but 8% is not a giant number. If we use injectable fertility drugs with insemination, it'll jump to 15 to 18%, and if you're over age 40, you can cut any number that I just said in half. So inseminations are certainly better than doing nothing, but it doesn't give us giant successful outcome. In patients who are using donor sperm as a means of getting pregnant, it's 3 to 6 cycles is reasonable. In patients who have other causes of infertility, such as a low but not a horrible sperm count, they ovulate sometimes but not all the time, they have one tube that's blocked and the other one is open, or a combination of little factors, or even unexplained infertility where everything is normal and we just don't know why someone's not getting pregnant, then 3 cycles is usually considered a reasonable attempt at success with an oral ovulatory drug and insemination before moving on to IVF. Now with IVF, the real benefit is the pregnancy rates. If we do in vitro fertilization and at the end of the day we have a normal, what's called a euploid embryo, an embryo that's been biopsied, has the correct number of chromosomes, and we transfer one normal embryo into a normal uterus, we're going to have a 50 to 60% pregnancy outcome with just that one embryo and a 10% miscarriage rate. So the miscarriage rate is half what it is normally, and the pregnancy rate is much greater than anything else we can do. The other advantage of IVF is it bypasses everything. It bypasses the fact that normally when you ovulate, ovulation has to occur. The tube has to pick up the egg. It has to transport the egg to the mid portion of the tube. The sperm has to swim up into the uterus and find the egg and fertilize it. And once it gets to the egg and fertilizes it, that embryo now has to be transported back to the uterus by the inner surface linings of the tube and then implant. So a failure of any of those steps can result in a negative outcome. And the good part about IVF is when you get the eggs and you fertilize them, the embryos form and you're putting the embryos directly into the uterus. So the only thing left beyond that is, will it work or not? But you bypassed all those other steps. And if you're doing genetic testing, you're taking it one step further because you're eliminating the embryos that have no chance of working. And then we can really limit our embryo transfer to a single embryo and have success rates of 50%. Now, somebody who's, if you look at age groups in general with IVF, per cycle that you stimulate patients, young patients under the age of 30, you're going to have pregnancy rates in that 40 to 50% range anyway. Women that are 41 and 42, the pregnancy rate is going to drop down into the 20% range, and women 43 and above, it's going to be 5%. The equalizer is if we have normal embryos at the end of the day, because even on a 42-year-old, if we have a normal embryo, that's going to give us that 50% success rate, the same as a 25-year-old. It's just that someone who's older tends to make less number of eggs, and a higher percentage of the embryos that form are not going to be normal, so it doesn't work as well. So how do we decide when to do what? IUI is a good trial if we have reasonable sperm that aren't 100% normal. And it's an excellent first step for donor insemination. It's an acceptable step for unexplained infertility, or a little of this or a little of that. But when you look at sperm factors or tubal factors, then IVF becomes automatically the answer is the best step. If you've got tubal disease or endometriosis, success rates with inseminations are going to be much less, and tubal pregnancy rates are going to be higher if there's hidden tubal disease present. If we're dealing with low sperm counts, the lower the sperm count, the lower the chance of success with inseminations. In men with less than 5 million sperm, the chance of success with inseminations is no more than a couple percentage points. Now, with insemination, you can do it natural cycle, which we don't usually recommend. You can do it with oral fertility drugs, which is either Clomid or Femara, also known as letrozole. Or you can do it with injectable fertility drugs rather than Clomid. And the injectable fertility drugs are called gonadotropins. And sometimes you can use a blend. You can use a combination of Clomid plus very low doses of injectable fertility drugs. And what you're trying to do with that is to get more eggs to ovulate. So if you get 2 or 3 eggs ovulating, you got a better chance of getting pregnant than just 1 egg ovulating. But even with injectable fertility drugs, in someone who's under age 40 with unexplained infertility, we'll go from an 8% pregnancy rate to a 15% pregnancy rate. Is it worth taking injectable medications, having more regular ultrasounds for only a 15% success rate, where if we went to IVF, we can get a 50% success rate? So most patients, most of us will try inseminations with Clomid first for a couple months. If after 3 cycles it hasn't worked, then we can go to either injectables or IVF. With most patients, I say 90% going to injectables. In some patients where we think they have diminished ovarian reserve or may respond better to injectables or have had Clomid treatment previously, we can use what's called a mini-stim approach, which is a combination of clomiphene plus low-dose injectables. And the benefit there is, again, trying to get 2 to 4 eggs rather than just 1, but we're trying to avoid high order multiples. The multiple birth rate with oral ovulatory drugs is 8%. Most of those twins, triplets, 1 in 1,000. With injectable fertility drugs and insemination, multiple pregnancy rates are 20%, and 20% of those can be more than twins. So 4% of pregnancies can be triplets or more, which create a big problem from a maternal and embryo standpoint. And then if a triplet pregnancy exists, then one needs to consider selective reduction to try and minimize the complications of prematurity and things that are associated with that. The benefit of IVF is with the transfer of just 1 embryo, the multiple birth risk is only about 2%, 3% at most, where you can have a single embryo split. And it's very, very remote to go from a single embryo to a triplet or more. So we can pretty much minimize or eliminate the risk of high order multiples by doing IVF and transferring just a single embryo. In patients with polycystic ovaries, if they're non-responsive to Clomid or not getting pregnant with Clomid, you can go to injectable medications. That subgroup is very difficult to stimulate with injectables because they often will go from not responding at all to sort of an oh my gosh response where they make 20 eggs. And 20 eggs is terrific if you're doing IVF, but it doesn't work if we're trying to get you pregnant naturally with insemination, because we don't want you to give birth to a whole soccer team. So in that case, again, if you're going to over-respond to low doses of injectables, and we can try often, but if we see that it's an all or none response, and we're getting that all response with 20 eggs developing, then IVF becomes our only option. One of the factors that I haven't talked about is the issue of diminished ovarian reserve. And this is when you look at somebody's ovaries and you count antral follicles at the beginning of the cycle, or we have an AMH level that's suboptimal, or an FSH that's a little borderline. If there's a signal that at any age, whether you're 25 or 40, that you have diminished ovarian reserve, what that tells us is that the total number of eggs in the ovary is not as many as we'd like. And the eggs that are there don't respond as well to fertility drugs, particularly in women that are over 35. They have a higher incidence of forming abnormal embryos when they conceive, and that's when they fertilize, whether that's internally, naturally, or in a dish with IVF. So when there's diminished ovarian reserve, our concern is we don't have as much time in the big picture. And this also raises a second question to couples is, okay, you're trying to have one baby, which is obviously the major goal right now, but the other is, what's your long-term goal? Ideally, do you want to have 2 or 3, or how many in addition to what you may already have if you already have a child at home? So the question comes as to, if someone comes in and they have diminished ovarian reserve, or let's say they're just 41 years old and they're trying to get pregnant, if the goal is, I'd like to get pregnant, but I really want 2, and I only want one at a time because that's the safest pregnancy, then IVF becomes a much better option, because we can actually collect embryos and stockpile some before we start transferring them. Whereas if you get pregnant right away, it's going to, by the time you get pregnant, have a baby, recover 6 months later, and ready to have another one, it's almost 2 years down the road. And if you're 41, now you're 43, and our chances of being successful at that particular juncture is going to be a whole lot less than at 41. So the idea of, do we want to stockpile embryos, do we want to preserve fertility at the same time that we're treating you, becomes an issue. But getting back to diminished ovarian reserve, if you have somebody whose AMH level is a little bit low, we know it's a chronic decline, basically. It's not going to change drastically in a month or 2, but it may in 6 months or 12 months. So we don't want to waste a whole lot of time treating patients with treatments that don't work very good, if we can treat them a little more successfully by cutting to the chase, basically. So in patients with diminished ovarian reserve particularly, we will often talk about, hey, should we try intrauterine insemination at all with a fertility drug? And if we do, certainly limit it to no more than 3 cycles. Often in that subgroup, me particularly might recommend a mini-stim protocol, just to try and get an extra egg or 2 out and get a little better pregnancy outcome. And if not pregnant in 3 cycles, then move to IVF, or really even consider going to IVF directly. And even somebody considering donor sperm, if they have diminished ovarian reserve, you're always going to get a better outcome with IVF. We can try inseminations, but how often do you try it before saying, okay, it's not working? If the only thing that's not working is ovulation, and we're doing IUI for ovulatory dysfunction and timing purposes, I would do up to 6 cycles, assuming everything is going right. But in all other cases, unexplained infertility, male factor, diminished ovarian reserve, a little bit of this, a little bit of that, infertility, 3 cycles is a good trial, and if you're not pregnant, then IVF makes sense. The ovary isn't going to all of a sudden fall off a cliff in 3 months, but it's continuing to decline with diminished ovarian reserve, and in 6 months or a year, it could be a big difference in our potential to get more eggs and be more successful. So, to summarize, IUI and IVF, these are our 2 basic treatment arms that we have available. Intrauterine insemination, most commonly combined with an ovulatory drug, and in vitro fertilization. It's common to start with the fertility drugs with insemination for people who don't ovulate, for donor insemination, and for couples with mild male factor that have reasonable sperm counts and good ovarian reserve. In patients who have very severe male factor, in patients who have significant diminished ovarian reserve, for patients who have tubal disease, IVF is going to always be the better approach. And it's just a matter of, okay, do we go there right away, or do we try something a little simpler before moving on? And if we're going to take that approach, or we're going to try something simple first, again, 3 months is the most we'd really recommend before moving to IVF. Cost-wise, IVF is obviously more expensive because the medications are more expensive. It's a much more involved procedure as far as stimulating with the medications. You need more ultrasounds. The egg retrieval is done with sedative anesthesia. And if we're genetically testing the embryos, we have to biopsy them, send them to a genetics lab, freeze the embryos, and then program the uterus to put them back in. And we'll be happy to go over individual costs with you. You just call our office and ask for a financial consult, and our financial counselor can review that in detail. If you're doing IVF, we have what's called a fertility assurance package that most patients find beneficial. So rather than just doing an a la carte single cycle, it includes freezing the embryos, transferring the embryos, doing all the frozen embryos, and if you run out of embryos, coming back and having a second cycle included. So that's called the fertility assurance package for IVF. Question: if I froze eggs at 35 with 12 eggs, I'm turning 40, and that I froze, and the eggs that I froze at 35, not one embryo back. If I'm assuming you're saying you had 12 eggs and they didn't turn into any normal embryos, or you haven't transferred them yet. Anytime you preserve fertility, you can expect with egg freezing, we would expect 15 to 20% of eggs not to survive the freeze-thaw process. Of the eggs that then fertilize, the eggs that survive, normally with frozen eggs, you fertilize 75% of them, unless there's an additional male factor. It may go down a little bit, but in general about 75%. The third factor is the aneuploidy risks associated with it. Of eggs that fertilize, around 40 to 50% will develop into nice blastocyst embryos, and at 35, about half of them will be normal. So normally our recommendation is that to feel good at age 35, that you have a reasonable chance of having a baby from that batch of eggs, we recommend you have about 20 eggs frozen. At age 40, you need twice that much, because not every egg is going to make it, not every egg is going to fertilize, not every embryo is going to develop. And again, this goes back to what's the risk of aneuploidy in general. If you look at women 30 in embryos that form naturally, 30% of embryos are abnormal. You look at women 35, it's 50%. You look at women age 40, it's about 70%. But if you freeze your eggs, it should take on the characteristics of how old were those eggs when they were frozen. If it's 35 years old, it'll have an aneuploidy rate associated with that. Someone said, I'm 40, can I try again? The answer is yeah. The answer is, why isn't it working? It's just an age factor. We know that, unfortunately, when you're older, you got to hit your head against the wall more often. It hurts more. It's harder to get people pregnant when they're older. It's harder because the ovary tends to not respond as well to fertility drugs, and of the eggs that either ovulate with ovulatory drugs with insemination, or embryos that form in a laboratory, a lot of the embryos just aren't normal, and abnormal embryos stop developing. So, either the embryo stop, you could fertilize the egg, the embryo stop developing, you don't even know if you're pregnant because you get your period. That happens with IUI. It happens with IVF if you don't biopsy the embryos. If we biopsy the embryos, at least we know we're putting a genetically acceptable embryo back in. Vitamins and egg quality. Vitamins are a supplemental approach to that. In general, we have a vitamin brochure. If you call the office, we'd be happy to send it to you, or you could pick it up. There's not a whole lot known about vitamins as far as doing good comparative tests, but in general, DHEA, 25 milligrams 3 times a day, L-arginine, 500 milligrams a day, CoQ10, 200 milligrams a day. Having some omega-3s either in your dietary supplements or just eating salmon twice a week is helpful. There's stuff of royal jelly, which comes from a bee extract, and some other things, vitamin E, that people think may be helpful. Acupuncture may or may not be helpful. The acupuncturists think it increases blood flow to the ovaries and may be beneficial. Doesn't do any harm. I found that it helps people relax and make them a little less stressful during their cycle. Whether it actually improves egg quality or not, I'm not so sure. But the less stressed you are, the better off you are. And from that standpoint, it has some benefits as well. That, I think, summarizes things. So again, our two biggest approaches to treating you guys are intrauterine insemination and IVF. They both have their place. If IUI doesn't work, then certainly IVF is the next step. And it's just a matter of when is it better to start with IUI or start with IVF. And that depends on the things that we spoke about earlier. Depends on the condition of the sperm, your ovarian reserve, and conditions of the tube. Doing one treatment doesn't prevent the other treatment from working. So if you try IUI, that doesn't affect your ovarian reserve in any significant way to do IVF if it doesn't work. The major issue here is just time frame, in that you don't want to do IUIs till the cows come home and you wasted 6 or 12 months when you're 37 or 38 years old, or you have diminished ovarian reserve. You want to do what's going to get you to what you're trying to accomplish, which is having a nice, healthy baby and a safe pregnancy. So we're here to help you get pregnant. We're here to help you try and do that in a cost-effective way. Costs are important. Even though IVF costs more, it works so much better that often when you look at it as how much does it cost per baby being born, IVF is much better. The condition of the uterus is always important. Also, remember, no matter how you get pregnant, whether it's IUI or IVF, if there's scarring in the uterus itself, that should be corrected before either of those two procedures take place, before you inseminate or before you do IVF with putting an embryo back in, because if there's scar tissue in the uterus, the outcome will be suboptimal. So that's the whole story. If you have any additional questions, please ask me, ask my partners, and thank you for joining us today. And I hope this was helpful in helping you understand your treatments that we're offering. Have a good day and stay safe.